Hello everyone, welcome to ecancer discussions. I'm Dr. Loriot, I'm a medical oncologist here at Gustave Roussy in Paris. And I'm pleased to welcome Dr. Scott Tagawa for the discussion around data on bladder cancer during this ESMO. Is it needed to introduce Dr. Tagawa, professor of medicine and urology at Weill Cornell Medicine. So thank you, Scott, for accepting this discussion. We will focus on FGFR alteration and inhibitor during this discussion, but maybe to start off the discussion, what are the most important clinical updates around bladder cancer treatment from ESMO to you?
So there have been a number of different what I would call practice-changing studies and presentations and publications in 2020 in general, some of which came at ESMO. What I would say overall is that frontline cisplatin and platinum in general is hard to beat. So adding immunotherapy or even in subsets, immunotherapy working better than platinum chemotherapy did not work. But luckily, what we saw earlier this year is that switch maintenance from platinum-based chemotherapy to avelumab in a separate study with pembrolizumab does work well. So I think there have been advances in terms of improving the overall survival of our patients with metastatic urothelial carcinoma. So that's what I'd say at a very high level, combining all of the different studies together.
Among the different therapies we have or will have in Europe, the FGFR inhibitors. So to you, what are the challenge and opportunities for the management of patients with FGFR alteration?
So one of the challenges initially, I think, for the average practicing clinician is identifying the patients. And this goes beyond identifying patients like we normally would for cisplatin based upon clinical characteristics. We need to look at tumor characteristics, because if we look at the population of tumors that represent metastatic urothelial carcinoma, it's the minority that will have an activating FGFR2 or 3 mutation or fusion. And it actually is 0 if we don't test for them. So we need to get used to testing for them. We've had the potential luxury of not usually having to test for PD-L1. So it's not ingrained in us like it is for, let's say, non-small cell lung cancer due to testing. Now we've had access to erdafitinib in the United States for a while, and hopefully that's coming to Europe. So beyond just on the academic research platform, we need to get this ingrained to the general practicing clinician. Luckily, I don't know if you're going to ask me this, but luckily we can do this with two different types of platforms: tumor tissue itself or plasma, looking for cell-free DNA. There is a subtlety having to do with fusions that we would like to have some RNA built in the platform. But luckily for urothelial carcinoma, we are usually in the mutation realm rather than the fusion realm, unlike, let's say, cholangiocarcinoma. So it is easier, kind of in a genetic DNA-only platform. We'll still capture the majority that happen to be FGFR3 mutations.
In daily practice, do you test on the plasma, the cell-free DNA, or the tissue? And what are the pros and the cons of the two approaches?
So I use both, particularly for urothelial carcinoma. So the clear advantage of plasma is that it's easy. Like you can see the patient sitting in front of me. I'm generally checking a CBC or chemistry anyway. I can just add that sample, so it's pretty easy. And the other nice thing about it, although we have yet to find a true use for this, is the potential for serial assessments. So that's what I would say. Luckily, if we're talking about FGFR3, it does tend to be an early alteration, so it's not something that we have to worry about so much changing down the line, at least to the best of our knowledge. The downside to plasma is it is probably not quite as sensitive. So if there is a positive result, I believe that. If it's negative, it's possible that we might be missing something. And that's why I'll go to tumor. Tumor would clearly give us the depth of coverage. The disadvantage is its heterogeneity. We're looking at not only one tumor, but one spot where the needle went within the tumor. But luckily, as we're talking specifically about FGFR and 2 or 3 alterations, they do tend to be early and persist. So in my mind, there's a little less of that issue in terms of heterogeneity, but it, it does boil down to where that needle went in. The other disadvantage of tumor, at least potentially, is what's available. So we can order in academic centers a metastatic biopsy. It's not always the easiest, but it does appear that, at least if we're looking at, let's say, a cystectomy specimen or a nephrectomy specimen, if it was there, specifically talking about, let's say, an FGFR3 point mutation, it probably is also going to be there down the line in metastatic disease. So, there's pros and cons to both plasma and tumor testing. What is nice is that both are fairly widely available.
And Arlene Sifko-Radke reported an analysis of cell-free DNA collected from the plasma in the BLC 2001 study to try to identify patients who benefit the most from erdafitinib. So the question is, what are your views on this abstract and work?
So, I like, as a general, I like any study that includes biomarkers. This happens to be, as far as we know, predictive biomarker, but we don't have so many that are not treated. But there may be certain mutations that result in better responses. I don't know that that's true. So first of all, it's a relatively small data set of approximately 100 patients, and we don't have randomized data yet. I think that it's hypothesis generating, and we may be able to validate that down the line with a larger data set, particularly a randomized data set, which is the confirmatory study. So I think it's very nice to have so far, but I wouldn't exclude a patient from treatment, for instance.
And there were some data on FGFR alterations in non-muscle invasive bladder cancer regarding the prevalence of the mutations. So what do you think about the role of FGFR3 mutation in this context in non-muscle invasive bladder cancer?
So, the longer term dogma has been that for non-muscle invasive, it's there in the majority rather than the minority of metastatic specimens. And it may not actually be the majority, but it is clearly in all the data sets more common in non-muscle invasive disease. So that's just a fact. And it may be also enriched in upper tract that I'm not so sure about, but that might be also true. So I think that has implications for the use of FGFR targeting agents in earlier stages of disease, because a major unmet need worldwide remains upper tract, where it's harder to use intravesical therapy, and bladder that is resistant to BCG. So again, we need to, if we don't identify those tumors, we're never going to be able to take the next step. There is also an association with the subset that tend to be enriched for FGFR3, and whether you're talking about TCGA subsets or other genomic subsets that might do less well, for instance, with PD-1, PD-L1, but that is not fully validated. But the more data that we get, the better it's going to be, particularly as we're now moving to the era of different choices in terms of therapy.
Another question, the big challenge we have with target therapy is resistance, obviously. And one strategy to try to overcome resistance is to combine target therapy with something else. And we have updated data from the NORTH trial, which combines a trimab, a PD-1 inhibitor, and erdafitinib. So what do you think about this combination in terms of activity and safety?
So it makes a lot of biologic sense, based on what I just said. So FGFR2/3 driven tumors are going to be enriched for FGFR2/3 targeted therapy, and might be de-enriched or might be more resistant to single agent PD-1, PD-L1s. So that combination does make sense. What we saw from the initial part of NORSE, which has been updated, is the tolerability, where essentially the full dose of erdafitinib can be administered with a PD-1 inhibitor, although those of us that have used it in trials and in the clinic in the United States will know that it's not necessarily any, multi-kinase inhibitor or something that's targeting FGFR 1 through 4 is going to have toxicity. So even though we might want to up titrate from 8 to 9 in those that don't have a major phosphorus increase, that is a little less clear if that's going to be the best tolerable strategy going forward in terms of a combination approach. But hopefully it's actually not as important with the combination strategy. We know that from other combinations that we don't necessarily need the full doses of each individual drug, and as there may be either additive or hopefully some synergy. And the nice thing about NORSE is that it does include a randomized component, so we'll see what happens kind of in the future.
We saw very great data on biomarker in the JAVELIN study. It was a big program. So what do you think? What did your take-home message regarding this program of biomarker in this study?
Well, the take-home is that we still need more work, honestly. So one thing to remember about JAVELIN is that the tumors had to have at least stable disease to get in. So we can't have anything there that truly says resistance to chemotherapy and immunotherapy because they didn't get into that trial. That's one aspect. The other aspect is it's fairly clear that PD-1 or TMB alone, or even in combination, don't tell the entire story. And those were the most maybe ready for prime time, but I would not call them prime time. The genomic signatures look very interesting to me, but really hypothesis generating, so we need to look at those in additional data sets. But if we don't do the initial studies to generate the hypothesis, we can never validate. So it's great to have that out there. And it's also great to know that in a large pharma-driven study, to be able to collect the studies and do the work is very important.
I think we are on time. So thank you, Scott. Thank you for your very useful insights. Thank you for listening, and see you next time at ASCO ESMO for hopefully new great data in bladder cancer field. Thank you, Scott.
I agree. Hopefully in person.